to the Acute HIV and fourth generation HIV testing webcast. We are pleased to be with you today, and we've got Dr. Peter Leone from the University of North Carolina at Chapel Hill with us, and I am Jennifer Shoup, and I'm the Senior Regional Product Manager for Abbott Diagnostics. Today we're going to cover the HIV epidemic and the importance of acute testing. We'll start off with new, or I guess not so new anymore, but the U.S. Preventative Task Service's recommendations, a grade A recommendation on HIV testing, why routine HIV screening is important. We'll talk about acute HIV in the window period, and then fourth generation, also known as HIV combo testing for acute HIV, and we'll review a case study. And then we'll get into our pilot program to educate clinicians and providers and patients, again, on the importance of early detection. We'll close with a resource page and contact information. So let's get started. I'll turn it over to Dr. Leone.
All right, thank you, Jen. As we've already said, we're going to talk about HIV testing and screening, what's available out there, and why this is important. What I want to start with, though, is that it is now recommended, and it's been endorsed, put forward as a grade A recommendation by the U.S. Preventative Service Task Force, that all adults in the United States be screened for HIV infection. And by adults, we're talking about anyone between the ages of 15 and 65. Now, my own personal opinion is that any sexually active adult should be screened. So if you're 70 or 75 and you're sexually active with someone who has not been tested, or you don't know their status, you should also be screened. But clearly, from an economic standpoint and from a benefit standpoint, we now have a recommendation, grade A, that all adults, no matter what their risk factors, should be screened. By getting a grade A recommendation, we now know that that will be paid for by insurance companies and Medicaid because of the Affordable Care Act. So this is something now that should be put forward. We know that in younger adults and older adults who are at increased risk, they should also be screened, and the CDC's recommendation are for particularly high-risk groups like MSM, screening should be occurring more frequently than even once or even once a year. For MSM, in which they're not in mutually monogamous relationships with someone who is HIV negative, we will be recommending screening every 3 to 4 months. But again, to reinforce the Preventative Task Force recommendation, annual screening. Next slide. And why is this important? If you look at the prevalence and incidence of HIV infection in the United States, starting from about 1980 through 2010, you'll see two lines here. The red dotted line is talking about people living with HIV, and that line has continued to go up. Now, that reflects two things. One, we're not seeing people die the way they did in the late 80s, early 90s. Now that we have effective therapy, people are able to live a normal lifespan if they have HIV. So as a result, that line is not going down. But it is going up. And the reason why it's going up and continues to go up has to do with the bottom line, which is the fact that new infections remain relatively flat since the middle of the 1990s. We're seeing about 40 to 60,000 new infections a year in the United States. That's in spite of the fact that we've known for a long time how HIV is transmitted, and we think we can take adequate steps to prevent transmission. And the next slide. So what's contributing to this flat incidence? One of the big factors contributing to it is what you see here. We estimate now that about 20% of folks living with HIV in the United States are unaware that they're infected. But that group of individuals, that red bar at the top here, accounts for over half of all new transmissions. So we really need to expand our base of screening to identify those folks who are infected, walking around with HIV, and not taking steps to prevent transmission to someone else. It puts them at risk for progression of their HIV, but disproportionately contributes to ongoing transmission. The second part is what's listed down below here, is that acute HIV, the new incident infections, contributes even more to transmission. And we're going to spend some time talking about why that's important and how do we make sure we're finding folks with prevalent infection, meaning folks who have been infected for a while, HIV measurable in the blood, or HIV viral load. We know that when a person is infected with HIV, the incubation period for HIV is about 2 to 3 days to about 2 weeks. Once a person is infected, about 95 to 97% of folks will develop viremia that is sustained, that is measurable. That first blip up of virus in the blood happens at about 2 to 14 days after a person is infected and quickly ramps up. So you see this quick upslope here in the amount of virus in the blood, which is also reflected in genital secretions, and it is literally the highest amount of viremia that we will see, with copy numbers in the hundreds of thousands to millions. Over the course of weeks, that number comes down and plateaus out. That plateau phase determines, one of the factors at least, it determines how quickly an individual will progress with HIV. So, quick upswing with virus within a matter of days to weeks, and then a flattening out, but it doesn't go down to zero, it remains flat. That means anytime you see this blue line, that person is potentially infectious to partners in which they share needles, blood products, or sexual partners. If we go down and look at genital secretions, which is the solid black line, you can see that that line mirrors what we see in the blood. So that peak period for virus in the blood is also reflected in terms of peak period of virus in the genital secretions, which means that this first 6 to 8 weeks we see some of the highest viral loads both in the blood and the genital secretions, which leads to transmission. If we look at the dotted line, that refers to CD4 counts. What happens in the acute phase is there is a quick dropping off of CD4s. Frequently that will bounce back up even without treatment, but not back up to the level that it was before, and then that person starts on the slow decline in CD4 counts over time that will eventually lead to an AIDS diagnosis and death if that person is not identified and treated. So our goals here is to identify folks that are HIV infected, reduce the viremia down to below detection, and maintain that person's immune system in a healthy state. So we want to identify folks as early as we can. And the theoretical window on that period is wherever the blue line is, we should be able to pick people up. The limitation of that has been, 1, getting people in, 2, making sure that we get the test to them, 3, getting the right test, and then 4, interpreting that test correctly. So let's go through tests and what tests will help us to identify folks. What we currently have in terms of antibody tests are third-generation antibody tests. For the most part, the rapid tests that are available are all third generation in the United States, and they only, or most of them only, include IgG, which means that they're good at picking up a more developed antibody response, but they only measure antibodies. That window period, meaning the period of time from infection to when that test first becomes positive, and it's the solid red bar going across here, is at about 3 to 4 weeks. So there's a time period in which a person is infected, has viremia, and yet an antibody test may be negative. That person then becomes positive at about 4 to 8 weeks and will remain positive for some time. If we screen individuals with antibody tests, we can only measure what we see in terms of antibody production. The question is, how do we pick up individuals' virus if antibody is not present? Well, the green bar is what we can do by doing individual RNA tests. You can see that that turns positive very early, somewhere within a day or two of a person being viremic. Because of this high ramp-up period, that test will remain positive early on, remain positive in about 97% of folks who become HIV infected. But the issue has always been it's an expensive test. There's only one FDA-approved diagnostic individual RNA test in the United States, and that test is a qualitative rather than quantitative test. And that individual RNA testing is really not feasible. So what we would like to have is a test that will tell us both RNA copies and antibodies, and that is the blue line. We now have fourth-generation tests, which are combination tests, tests that will measure for antibodies and virus at the same time. In measuring virus, it looks at P24 antigen, and it is very RNA test, but pretty darn close. And so if we look at this bar, we reduce the window period here down to about 2 to 4 weeks. Now, that means that we can identify folks during this period of HIV in which antibodies are not present, but they have virus present in their bloodstream. Therefore, identifying them as being HIV infected, referring them into care, getting them on treatment, and hopefully reducing their risk of transmitting HIV to someone else. Now, many folks say that we should be limiting HIV testing to folks with fourth generation based on signs and symptoms. There are some problems with that. If you look at the gray box here that's sort of outlined in orange, is referring to the acute retroviral syndrome and symptoms associated with that. What we know is in men, at least, about 80 to 85% of folks who become HIV infected will develop an acute retroviral syndrome. Those symptoms, though, are pretty nonspecific. They are fever, rash, swollen lymph nodes, may present with an aseptic meningitis picture. They may have low white blood cell counts and low platelet counts. They can present with GI symptoms, nausea, vomiting, and diarrhea. It's very hard to sort this out from other nonspecific viral illnesses. And in addition, if you notice where this box is, that a person who presents with these symptoms, antibodies lag behind the presentation of symptoms. And if you go out even further to the left, you can see that viremia occurs several days to maybe even potentially a week before the onset of acute retroviral symptoms. So the issue is, if we're going to do screening, you could say, well, fine, we want to try to identify folks during this acute phase, and we can only screen people with a fourth-generation test, say, or RNA testing during the acute viral phase. The problem is that many folks are viremic before they develop symptoms, and our own experience in North Carolina is that although 80+% of folks develop an acute retroviral syndrome, only about 25% of those individuals at the time of testing even mentioned their symptoms. It was only after they were diagnosed and they were specifically queried about the symptoms that we gathered information around that. So I really think what we should be looking at is what is the best test that we can use to identify folks earliest during infection and not depend on trying to figure out which test we should be using at which time period. Next slide. Now, all that's important because the idea is not to miss anyone who's infected. So if we look at this slide, you can see we have the percent of positive individuals here, meaning if we look at folks with acute or recent infection, what percentage of those individuals can be identified with each one of the different tests that are currently available or were available. We'll start off with the left with first and second generation HIV antibody tests, and you can see that it was not a very good test to pick up people during that first 4 to 8 weeks after someone's acquired infection, missing almost 90% of individuals. If you go to the next part here, you can see Western blot is sort of stuck very close to what we saw with first and second generation tests. Now, we're going to come back to this issue on Western blots in a little bit. Western blot had been the standard test for confirmation of a positive HIV test, and that made a lot of sense when the performance of that test matched what we were using as our screening tests in terms of sensitivity. But as we've improved the sensitivity of our assays, we've moved further to the right, while the Western blot has stayed stuck sort of at the left. It's old technology looking for evolution of an antibody response before that person is called positive. As a result, a Western blot for confirmation, especially during the acute phase, is an awful test, and one of the reasons why we're moving away from Western blot confirmation. If you go further to the right here, you can see that the rapid test, generally speaking, will miss the majority of acute HIV. That includes things like OraQuick, Unigold, and even the multi-spot, the 1-2 multi-spot. If we go over to the third generation test, those frequently include IgM and in combination with IgG antibody detection, but they still miss around 60% of all of the acute or recent infections. It's only when you include a combination test that looks for antibody and antigen can you pick up folks during this acute phase, and that's about 90% compared to individual RNA majority of folks during the acute phase and allows us to identify folks up to 20 days, almost 3 weeks earlier than standard antibody testing. Next slide. So let's bring this into real-world perspective. What happens with a client presenting? And I'm going to give you a real case study here from North Carolina. We'll start off with patient A. Patient A presented in July with a fever and a headache, and he went to one of his local emergency rooms. There he was seen and evaluated, had laboratory testing done, and had an LP to rule out a septic meningitis. It turns out that he had a low white blood cell count on his LP, indicative of what they thought was an aseptic viral meningitis or possibly Rocky Mountain spotted fever, and he was given a possible diagnosis of Rocky Mountain spotted fever, given doxycycline, and discharged. That all made a lot of sense, but his symptoms got worse. He then reappeared in a different emergency room 2 days later, was admitted to the hospital, and actually had an ID attending who saw him in the hospital there and ordered an HIV antibody test. His antibody test was negative, and he was discharged with a diagnosis of aseptic meningitis, still possible Rocky Mountain spotted fever, but he was getting better. Now, this is what I would call true, and unrelated. Yes, he had a headache, he had an aseptic meningitis, yes, he was on doxycycline, and yes, he was getting better, but it wasn't because he had Rocky Mountain spotted fever. And yes, his antibody test was negative, but indeed, as we'll discuss here in a second, we couldn't really rule out HIV infection by the antibody test alone. Well, he went out, he met partner B in August. They engaged in unprotected sexual intercourse about 3 to 4 times. Partner B was also a roommate of partner C. They engaged in their routine sexual practices of about sex once or twice a week, but partners A, B, and C also engaged in 3-way sex at the end of August on October 30th. September 10th, partner B developed a fever and sore throat and fatigue, went and saw his local primary doctor, was given a prescription for azithromycin, was never tested for HIV, and over the course of a week or so, got better. About 3 weeks later, his roommate developed very similar signs and symptoms with a fever and sore throat, went to see his primary care physician, was also given a prescription for azithromycin, and also got better. Neither patients B nor C were tested for HIV, and they assumed because they got better, they didn't have anything else that they needed to worry about. They met patient D, had sexual intercourse with that individual in mid-October, and about 2 weeks after that, patient D developed a fever, sore throat, oral ulcers, and thrush, went into an urgent care center requesting HIV testing and STD testing. They did STD testing, and all of his STD results came back negative. However, he got worse with diffuse lymphadenopathy, went back into the urgent care, who referred him to a university center where he had HIV testing done. We'll go to the next slide. Patient D had a positive ELISA and an indeterminate Western blot. He was told he might have HIV during the acute phase. He contacted his 2 previous partners, patients B and C, who came in to be tested on World AIDS Day. They were both found to be positive. I interviewed both of them, asked them about signs and symptoms, got their history, and realized that they had been in contact with someone else. Patient A, our disease intervention specialist, went out and located that individual, tested him later in December, and all of these folks turned out to be HIV infected. So what we saw here was acute to acute transmission, where because the diagnosis was missed based on not ordering the right test in patient A, we saw downstream transmission to 4 other individuals. I diagnosed the first person, we could have prevented downstream transmission. Now, this may seem obvious to you because this is an MSM network, but I would also say that in low prevalence settings, we frequently find HIV. We'll go to the next slide. So if you look at some early small numbers in what I think all of us would consider a site with low morbidity HIV, South Dakota, Sioux Falls, South Dakota, they instituted 4th-generation combination testing in November of 2010. In 2008, there were 28 new cases of HIV in the entire state of South Dakota. Within the first 7 months of using combination in that hospital, they identified 4 new cases of HIV, of which 3 of them were acute HIV, which illustrates that although we frequently think about high and low morbidity, it's the sites in which we offer testing and that nexus of where high-risk individuals or individuals with signs and symptoms consistent with HIV may present that we need to make sure that the right test is being offered. And the interpretation of that test is made that we can make the diagnosis. Have the next slide. And that's why we're really pushing to make sure that in cases or places in which we're looking at that intersection, 4th-generation testing is offered so that we can reduce the number of false negatives. The worst-case scenario here is telling someone that they don't have HIV when they do. And we know with 4th-generation testing we can reduce false negatives by about 90%. So let's go to the next slide. In order to do that, we recognize that we had to change our approach to HIV testing, and the CDC is putting forward a recommendation about offering our approach, and that is using a 4th-generation test as the initial screening test whenever available. If that test is positive, we then follow that up with an ELISA antibody test, in this case a rapid test, the HIV-2 rapid test. If it's positive, we know that that person has antibodies. They've been infected probably for somewhere around 8 weeks, and they are what we would call more prevalent infection. And we can determine whether that person has HIV-1 or HIV-2 based on their response to the multi-spot. But if they're negative to the multi-spot, the question is now that they have a 4th-generation test that's positive and an antibody test that is negative, we need to rule out acute HIV. In which case, that individual will then have an individual nucleic acid test that's done. If they're positive, they have acute HIV, and they need to be referred into care, period. And we would say that those folks should be started on treatment. This is one of the few cases in which we call this a public health infectious disease emergency. And we know that this person should be immediately seen and treated. If they are negative on the nucleic acid test, and this is a false negative 4th-generation test. And it turns out that the 4th-generation test is very good at picking these folks up, and the number of false positives are relatively low. Now, that rate of false positives is going to be dependent on the population which you're serving. But we also don't want to forget that a negative test in this case with the 4th-generation test essentially rules out that that person has viremia with HIV, or antibodies, which means that we can reduce now that window period down to about 2 to 4 weeks. Now, we won't have a test that will tell us whether a person who had sex yesterday is HIV infected today. But what we can say is that person is almost assuredly non-infectious if their 4th-generation test is negative, in which case further testing and evaluation depends on their risk factors and history. So next slide. This is all well and good, but testing, we believe, needs to be linked up with referral to care and treatment. And the reason for that, the pivotal change, is we now know that treatment is prevention. So the individual benefits by starting on antiretroviral therapy and preventing progression of their disease, but we can also reduce transmission, as you see on this slide. Early diagnosis and treatment with HIV can reduce transmission of HIV by over 96%. That means we could render folks virtually non-infectious. So remember that downstream case scenario that I gave you a second ago. Ordering the right test and making sure that person is screened will allow us to identify folks earlier, and if we link that person to care and start them on treatment, we not only benefit the individual of making the diagnosis, we can have an impact on incidence and reduce transmission. So remember our slide that I showed early on about the rising prevalence of HIV and the flat incidence. Our goal is to see a flattening of the prevalence and a decline to 0 of incidence in the United States. So we have the next slide. So with that, I'm going to turn the talk over to Jen again, who will walk you through a pilot patient education program that we think is really pivotal in helping us to accomplish our goals, which is to screen all sexually active adults, to identify these folks early in infection, to not miss acute HIV, and to link them into care. So Jen, take over.
Great. Thank you, Dr. Leone. So I am very excited to share this educational program with all of you. And it's for providers, clinicians, and ultimately patients. And we feel this will benefit your clinics and your practices, and most importantly, your patients, to help prevent all those new infections that Dr. Leone was talking about. So the goal is to prevent transmission and enable an earlier treatment. So we're raising awareness about the importance of early detection and accurate HIV testing. This is a pilot program in approximately 10 to 12 primary care and urgent care clinics in the United States, and those that are in the high HIV infection rates or zip codes, if you will. Why is this important? Because both patients and clinicians underestimate the risk for HIV testing. So they don't think that their patients are at risk, their doctor doesn't recommend testing, and they don't know where to get tested. So we feel this will be an important step in fighting the spread of the disease. And essentially, it's a toolkit with educational materials. So, and I'll walk you through what it includes. So as you see here, this is an overview of all of the materials. So it comes with a folder. And then inside the folder, there's two sides. One, the left side will be for providers and the right for patients. And then there's brochures and posters and pamphlets that will go through each one in more detail. So here's a quick picture of the inside of the folder. Again, left side will contain materials for the providers, and then the right side for patients. The first tool is a poster, and you'll be getting 3 posters in your kit, and these are where you would place these in areas where patients would have the time to read them, so perhaps a waiting room, restroom. And this goes into, it highlights the case study that Dr. Leone talked about, where missing one HIV case led to four cases of HIV, so, and potentially a 5th one. So very important to detect people early and get them on treatment. Next slide. The next piece is a patient pamphlet with a doctor discussion guide, and this is a tri-fold brochure, and it has important statistics on HIV, why you should get tested, and how you can fight the HIV disease. And your office will be getting 25 of these patient pamphlets. And then here's the doctor discussion guide. So it helps the clinician walk through questions, and patient vice versa, ask their doctor questions about HIV testing and why they should get tested and what tests are out there and which one is right for them. This is a slider, a patient education slider. So it goes through statistics of who is getting HIV, and really the message here is that there is no risk profile anymore for HIV. And it's kind of a fun way to educate patients, and you'll be getting 3 of these as part of your kit. And then this is for clinicians, so again, more stats and information about new infections in HIV, and then when to test if you see, flu-like or mono-like symptoms, and really to be safe in ordering a combo test or 4th-generation test, as that picks up both acute cases, new cases, and chronic or established HIV infections as well. And then we'll also have a couple of brochures for you. The purple one is a more technical piece on the assay and the test. And then the smaller red one is what we call our physician brochure, which kind of tells a story, sets up HIV, talks about the problem, and then how accurate testing can help fight the disease. So your role, what we're asking you all to do is that recommend most patients get tested. So, and also inquire about when they might have been exposed to HIV. with confidence. Again, as we mentioned, the 4th generation HIV combo tests for both acute, early, and that critical, highly infectious phase, and for chronic and established infections. So this test does require a conventional blood test, and then we also urge you to write HIV combo on your lab form, or even call the lab that you send your results to and ask them about getting an HIV combo 4th generation test. Here's another additional piece of information for your clinics. 4th generation testing does reimburse at a higher rate than the traditional 3rd generation methods. Now, this does vary by state, as you can see here. So we are not guaranteeing any payment from any of the payers, but you need to verify that with your own insurance companies and your own plans. But this gives you an idea. This is from the Medicare 2014 lab fee schedule on what a 4th generation HIV combo test reimburses. And I will say it's approximately, or on average, about $12 to $14 more than the 3rd generation test. And again, it all depends on your state and then contracts that you have with your insurance companies. So finally, this program is not going to require a whole lot of time on your part. Essentially, we would schedule a brief interview to review the program with you. We would ask that you complete a pre-survey just to kind of gauge where you are with HIV testing at this point, so we can measure the effectiveness of the program. We'll have a champion or a point person for the program, and then we'll send you the materials, and then we can walk through those with you over the phone. Again, I gave you a high-level snapshot of them, but they're pretty easy to use, and again, most of them they'll be on display for your patients to read and review as they're in your office. And then, we would like you to use these materials for approximately 2 to 3 months, and then after that period, complete a post-survey, which again will not take very much of your time, again, to see what the effect of the program was. Did you increase testing? Did you increase HIV combo testing specifically? We also want to see and make sure that you had a good experience with the materials, and if there's any feedback for the program. And then we mentioned in the beginning, this is a pilot program. We may consider rolling this out on a national basis, so we may ask you to participate if you would be willing in an advisory board for national rollout. But again, bottom line, not a whole lot of time that we're asking here, so less than 2 hours over a period of a couple months. And then in summary, again, U.S. Preventative Task Force recommends that everyone get routine HIV screening, so everyone from age 15 to 65, and grade A means that you will get reimbursed for it. And then routine screening is important. HIV is underdiagnosed. It's still a problem. Our transmission rates are flat. They have not gotten any better. We have 54% new infections each year. The acute phase is highly infectious and when most people are spreading the disease. The HIV combo test can detect up to 20 days earlier, which the key is getting people into therapy because, as Dr. Leone discussed, once they are on treatment, they can decrease the transmission by up to 96%, which is huge. So ultimately, this program and your help, we can hopefully together prevent transmission and really fight this disease. So we can't afford to miss HIV. And finally, here is my contact information. If anyone has any questions, my phone number and email is on here. And then also, we would encourage you to visit our website, hivcombo.com, that has, again, a lot of great educational information on the disease. And there's 2 different tracks, one for patients and for providers. So we think you'll find that useful as well. I want to thank you again for your time today. And again, we really hope you consider participating in this highly educational program, and we think, again, together we can all have an impact in fighting this deadly disease. Thank you again for your time, and have a great day.